Sorry about this confusion. Okay, so in the next few minutes, I'm going to talk about the role of chemotherapy in the non-rhabdo soft tissue sarcoma. So the adult type of soft tissue sarcomas are rare in adults, and they are even rarer in children. So a lot of data that we would use or use for the pediatric practice would actually be an extrapolation of the adult data. So I'll start with this slide. Are adult type soft tissue sarcomas chemosensitive? And I'm going to show you first an ugly tumor like this. It was so ugly in a child, but it did respond to chemotherapy. So the answer is yes, it is chemosensitive. We had an angiosarcoma in an adult, metastatic, came to the outpatient panting in 2008. The patient continues to be alive with paclitaxel till date. So they are chemosensitive in a proportion of patients. Now the question is, when you have a metastatic soft tissue sarcoma, in general, our intent is palliative, which is right. The response rates to chemotherapy are in the range of 15 to 45%, with 10 to 15% actually achieving a CR, and 1/3 of those who achieve CR can actually get cured or have a potential long-term survival. So if I say 1/3 of 15%, that means 5%, 5 out of 100 have a potential for long-term survival. This has been a question of multiple meta-analysis in adults. Does adjuvant therapy benefit soft tissue sarcomas? In adult, this continues to be questioned, but for children, for high-grade sarcomas, adjuvant therapy continues to be a practice for majority. So in adult, the data is controversial, but many would say yes. And just to summarize for the audience, I'll say that all high-grade tumors, size more than 5 centimeters, deep-seated and recurrent, would merit adjuvant chemotherapy. These are the effective agents for soft tissue sarcomas. While to the kitty, many agents have been added, but the anthracyclines continue to form the backbone. The next question is, does histology and site of the sarcoma matter for therapy? And the answer is yes to both these questions. And I'll show you how it matters in terms of choosing therapy. Histological type, a liposarcoma specifically sensitive to doxorubicin. In synovial, addition of ifosfamide to doxorubicin seems to have a significant impact. Leiomyosarcoma, gem and dosi seems a good option. Angio, paclitaxel, a good option. Likewise, for dermatofibrosarcoma, imatinib for chordoma, sunitinib for alveolar soft part sarcoma, and therapies like tamoxifen, diclofenac, imatinib, and pazopanib for fibromatosis. So the type of sarcoma matters. Coming to the subtype of some well-known types. So liposarcoma is a type, and well-differentiated or myxoid becomes subtypes. It matters to know this. Response to doxo, yes for myxoid, not for well-differentiated. Response to pazopanib in general, very low for liposarcomas. The next question is the same histology at different sites. Interestingly, leiomyosarcoma in the uterus is more chemosensitive than if it's the same tumor in some other sites like the vessel wall. Some questions and facts about preoperative chemotherapy in soft tissue sarcomas. Is it better than upfront surgery? Unlikely based on phase 2 data, but phase 3 data are lacking. Pre-op chemo plus versus pre-op chemo plus radiation, answer not clearly known. Will intraarterial therapy be better than intravenous therapy in the preoperative setting? No, as intra-arterial therapy would cause more wound complications. What is the ideal pre-operative chemotherapeutic drug or drugs? There is some data on that, and I will share that in the subsequent slides. So, while in my previous slides, I showed that specific histologies respond specifically to certain chemotherapeutic agents, and based on that information, this was a histology tailored neoadjuvant therapy versus standard therapy in patients with high risk soft tissue sarcomas. Contrary to what one thought, the above red line that you see in the survival curves is the one with the standard anthracycline based therapy. So the anthracycline based therapy seemed better than the histology tailored chemotherapy. This was a trial which recruited children and adults both. So in this, the endpoint was the pathological response with large unresectable high-grade sarcomas where pazopanib was added to chemoradiotherapy. So the result was that the pathological CR rate was much more when pazopanib was added. But is it going to result in survival benefit? Answer not known. This is the picture of an orthopedic surgeon, William Cooley. So I am switching gears from the traditional chemotherapy and going to update you what this gentleman tried in the late 1800s. The orthopedic surgeon, while working in Memorial Sloan Kettering, found out that certain sarcomas disappeared when they got infected. And he started a study where he injected bacteria or some organisms around sarcomas. It didn't work out, but then he worked in the lab and he's considered a pioneer of cancer immunotherapy. And the factor that he worked on came out to be known as tumor necrosis factor alpha. Now, we all know that tumor mutation burden is the frequency of certain mutations within a set of tumor genes, which would then alter the protein. And if the proteins get altered, the antigen expression changes and they would be recognized by the immune system. So the logic is that higher the tumor mutation burden, more likely it will be sensitive to the immune response from the body. So where do sarcomas stand with respect to tumor mutation burden? The general dictum is that tumors which develop with the mutagens have more mutations. So like lung, bladder, melanoma. But sarcomas don't really develop due to mutagens and they have a low tumor mutation burden. And so they are unlikely to respond to the immunotherapy. So two trials have been done with nivolumab and pembrolizumab in advanced soft tissue sarcomas, and the only sarcoma which showed some response rate was the undifferentiated pleomorphic sarcoma. Notably, the undifferentiated pleomorphic sarcoma the response rates did not show a correlation with PD-L1 expression, as has been the case in other solid tumors which have responded to immunotherapy. This is an interesting concept which was tried in adolescent and adults, where they combined a VEGF inhibitor with immunotherapy in alveolar soft part sarcoma. And the logic for this combination was as below. Alveolar soft part sarcoma has low tumor mutation burden and low PD-L1 expression, so one would think that it will not respond to immunotherapy. VEGF suppresses dendritic cell maturation and antigen presentation, so combining an anti-VEGF with immunotherapy was a logical decision, like as it has been tried in renal cell carcinoma, and in this tumor it showed a better response rate. I want to share an article on metronomic chemotherapy with best supportive care in pediatric solid tumors, and in that randomized trial, The subgroup analysis showed that it was the non-bone sarcomas which showed benefit with metronomic chemotherapy. And based on that, we actually just published a retrospective analysis of metronomic therapy versus pazopanib in advanced soft tissue sarcomas, and it was equivalent. So pazopanib, the alternative metronomic chemotherapy, seemed to be a cheap option to pazopanib. I will conclude with the following statements. The non-rhabdo soft tissue sarcomas are chemosensitive. Targets are now available for various subtypes, and hence subtype analysis should be done. If pre-op chemo has to be used, it should be intravenous and anthracycline based and not histology driven. Addition of pazopanib to anthracycline improves CR, but no data on survival. Immunotherapy has still not found its place in soft tissue sarcomas. Oral metronomic chemotherapy appears to be a good and cheap alternative to pazopanib. Thank you very much. And I want to thank the institute where I work, where I get this opportunity to see these patients. Thank you all for a patient hearing.